Okay, why are you upset?
No, I'm not. So no. I'll tell you. So I think as a pancreatic and a phase 1, I'm an eternal optimist. So that's the first thing. And I do think, exactly as Paul said, I think it was a great getting all these patients accrued. So we really have to tip our hats to the investigators of the study. To get this scale of study done is amazing. And we need more studies like that in pancreatic cancer, in which we're trying to find answers. So I don't think I was disappointed. I was much more hopeful for a better result when when
on
it was
the
going to come
side, I guess?
on overall, when it's at plenary, it's coming out. So I was excited about. I mean, last year when FOLFIRINOX adjuvant didn't get a plenary, and you're thinking, so I was very excited about it. So I think maybe I should have tempered my enthusiasm just a little bit. So I think the disease-free survival was 3.6 months improvement. I think that's great for our patients, right? Because I think we can give them a chemo break, we can put them on this. However, what the tempering part was the overall survival. There was no overall survival benefit. Granted, there was a 15% crossover, 15% patients did get a PARP, but still I was hoping, maybe in my mind I looked at the ovarian data, and if you see those curves, overall survival, they are much further apart. So when I looked at the overall survival curves this morning, that was a little disappointing to me, but that doesn't take away from the fact that I do think it really was. We need more kinds of studies like this in which we identify this patient population, screen 3,000 patients, but find that 5% of this patient that can really benefit. And I think it opens the door for further studies, combination studies, how do you target it better, and where we can go from here. So I'm very optimistic.
Allison, do you think this brings forward a new trial design in pancreas cancer? I mean, I think this is very bold to have a placebo, no treatment arm, even though it was 3-2 randomization. In responders in frontline as maintenance, as not only an outstanding investigator, patient advocate. What's the take on that side?
I also think that's the reason why it didn't accrue so well, is because people in the BRCA community knew that they could get this off label.
Yeah, you could get one, right?
You could get one off label, and why would I go on placebo when So
well, and even more evidence, I think, is that once you progress, that they're very hard to recapture. That these drugs are not as, you need to kind of catch them while they're down, is most of the evidence.
To point out on the trial, though, remember all the patients got 4 months of chemo first. So in the PARP arm, it was more than a year of disease that they were living. I mean, that they were, the survival time. And it was only less than half mature, the survival data. So we may see something come out of this more. Yeah, hopefully.
But it's back to this predictive versus prognostic.
I feel that where the trial should go now in this population is how can we harness the DDR pathway even more by combinations with chemo and or immunotherapy for this, or even vaccines.
And as GI oncologists, this is kind of a new drug class for us, but certainly I know our community partners use these things a lot, but they're not all the same, and they're not easy to combine with chemotherapy. So it's one of the reasons why these drugs are being isolated as single agents, is they don't really play well with some of our other drugs. So, there are other ones to come in this space.
But I think some of the other points is that even the patients who got placebo had a really good survival.
Yeah.
And so that sort of argues that maybe it is okay to stop everything, something I would have never done. I wouldn't call it a placebo.
In this group.
In a group that's BRCA mutated, that's done well,
Right.
it might be safe to say take 3 months off.
And that's why we need randomized studies like this, which is tells us exactly what the data is.